Just want to thank you very much for the invitation. It was always very, very exciting for me to come back to India. I've been coming, my first experience in India was 20 years ago when I was invited by Dr. Natarajan to operate in his hospital, and then I've been coming back for charity work in some rural hospitals, which were very, very pleasant, where we did not have all these wonderful facilities as far as sterilization is concerned. But anyway, thank you for having me here. As I said, it's always exciting to be here. I've heard these wonderful talks about sterilization and about how to keep the patient free from infection. But however, we know that we do get infection now and then. And we have numbers for that, and we know that as surgeons we're exposed to this complication. How many people here do surgery? Please raise your hand. How many people do VR surgery? Okay, so some of you, yes, I thought so, but some of you may just be interested in the basic concepts, and then someone else will take over, I think, from there. So my talk today is a reasoned approach to post-interventional endophthalmitis. Now, we know there are different sorts of endophthalmitis. I won't go through them. We have from trauma, we have iatrogenic. We are going to be dealing with post-interventional, and we know that we can have late onset complications, or we can have rather early onset complications being associated with cataract surgery or posterior segment surgery, mostly today with intravitreal injections. So I'll just run through what the microorganisms involved are. I think you can find this on any publication, any book, so I will not waste your time by looking at this. But obviously they are generally, we generally have the streptos and the staph involved in the anterior segment surgery, whereas the straps are more involved in the posterior segment procedures. What I'd like to drive, the points I would like to drive home today are essentially how you should face endophthalmitis. Now, endophthalmitis to me is something which should always be approached as something which is a surgical rather than a medical emergency. If you keep that in mind, I think it will just change the way your patient will be treated. Now, unfortunately, we have some conclusions from the early vitrectomy study, which I think are misleading. What the study said, and I think you're all aware that this study was carried out several years ago, what the study essentially said that there was no benefit in the use of systemic antibiotics or, which is more important, vitrectomy, unless visual acuity deteriorated to light perception. Now, the consequence of this latter statement is that vitrectomy was performed only on eyes which had poor but greater than light perception. This became the exception rather than the rule. So the consequences were that vitrectomy on eyes, so the consequence was that surgery was performed too late. Now, endophthalmitis is essentially satisfies the criteria of an abscess. So you know what an abscess is, and you have been through medical school, and you know that medicine teaches us that abscesses have to be drained. So what is present in an abscess? We know that we have bacteria, enzymes, cells from the body's immune response, and inflammatory agents of different sorts. So if you're going to be treating your patient with an intravitreal antibiotic, you may succeed in destroying the pathogenic agent, but you will not prevent the retinal damage, which is determined by the immune response, and the bacterial toxins and endotoxins. Therefore, this may result in a delayed or impaired functional recovery from the retina, which has been damaged not only by the germs, but all that goes along with the infection. I would also like you to think of endophthalmitis as a dynamic event rather than as a static event. This means that endophthalmitis has a tendency to progress. So when you're classifying endophthalmitis, please do not talk about please do not talk about moderate or severe endophthalmitis, as most people do, but talk about early or advanced. This will change your mindset, because if you find an endophthalmitis which is you think is moderate, it means it's early. It means that it will evolve into something more serious. So you're given a chance to treat that patient before this happens, and you should not lose that chance. So I would classify endophthalmitis in early or advanced rather than moderate or severe. Now, the rationale for vitrectomy is removing the infective agent more quickly and efficiently than could be achieved with antibiotics, and also removing, as I said before, the inflammatory component. Now, if you do not perform vitrectomy, you will delay and limit the possible rehabilitation, and you may require more operations. This has been seen that even in the early vitrectomy study, the group that did not have vitrectomy required further surgery in a greater amount of patients than the ones that did have vitrectomy. So where was the weak point of the early vitrectomy study? Essentially, they were afraid of iatrogenic retinal detachment. And also because of this, the protocol prohibited the posterior vitreous detachment and also limited the amount of vitreous which was to be removed. So it was recommended that about 50% of the vitreous was removed. Obviously, if you're going to be removing 50% of the vitreous, which vitreous do you remove? The one that is away from the retina, the one you can reach first. So actually, you were not doing anything to salvage the retina. You were just removing some vitreous. So you were doing what I would say an enlarged, augmented vitreous tap. Was this fear justified? No, it wasn't. It wasn't because it wasn't justified then, because actually the patients that did not receive vitrectomy had 2.5 times more retinal detachment than the ones that did receive vitrectomy, and it's certainly not justified today because we have had such incredible technical improvements in our equipment which make surgery so much easier even in these difficult cases. Furthermore, we have obviously a better understanding, and we have better surgeons. So the take-home message number one is vitrectomy is safe, a common sense approach to endophthalmitis. Now, what is the timing? Well, early cases in early cases, I think an attempt can be made with intravitreal antibiotics. You can watch these closely for the next 24 hours. For more severe advanced cases, you should treat immediately. Now, intravitreal antibiotics can be given as a temporary step, because when I say treat immediately, unfortunately, immediately is a concept which is not always attainable. You have problems with theater availability, with surgeon availability, and other issues. So if you think that you get a patient in at 8 o'clock in the morning and you're going to be operating at 8 o'clock at night, the picture will be completely different, because the ratio of multiplication of the bacteria is very high, especially for certain sorts of bacteria. So you will see a completely different picture. You may have a completely compromised eye. So in the meantime, while you're waiting to go to theater, what you can do is use as a temporary step, you can use antibiotics, intravitreal antibiotics, after having performed, obviously, a tap, which has to go to microbiology. So take-home message number two is that vitrectomy should be done early. The method, how much time do I have?
20
5 more minutes? Yes, thank you. So I would just like to go through the method. There are 4 steps to remember. If you're going to be, first you want to obtain anterior segment transparency, which may mean in certain cases that you want to, sorry, I don't know why the video is not working. But anyway, this should show you, oh, here it is. So in certain cases like this, obviously you have to use a TKP, temporary keratoprosthesis, to be able to, you have to sacrifice the cornea in order to be able to perform your vitrectomy. In all other cases, you obviously want to obtain a clear anterior segment, and you'd go, and then you can proceed going down by layers. Now, the first layer which you will find is the posterior capsule, and you do not need to remove that. You can actually simply perform a very large capsulotomy and keep the capsule in place. They don't need to remove the IOL. You then want to perform a complete vitrectomy as opposed to a core vitrectomy. When I say a complete vitrectomy, I mean as complete as you feel comfortable with. You do not want to run risks, but you want to remove as much vitreous as possible. I cannot give you a magic guideline. It has to be up to your good common sense. And then do not remove the posterior hyaloid. This is something you should not try and do because it is extremely dangerous in a very fragile retina. So the method that I generally recommend is something I've named posterior hyaloid fenestration, in which simply you try to, you can see the steps here, posterior capsulotomy and so forth, in which you try to open up the posterior hyaloid without exerting any traction on it, so that you will not be damaging the retina. I'm sorry I cannot go any faster here. You generally could. For some reason, it's not showing up here. But anyway, it will only take a few seconds. As you see, you start by aspirating here, the posterior hyaloid. You are making a small window, a very small window, which will allow the antibiotics which are in the infusion to come into contact directly with the most delicate part of your retina, which is obviously the macula. You do not want to pull any further, as you can see, because here, if you exert traction on this very fragile retina, you will obtain a break, which is the last thing you want. And so here you can see that the macula has been exposed, and we have what I said, fenestration of the macula. So the take-home message number 3 is vitrectomy should be as complete, as safely possible. And finally, the take-home message number 4, many people ask me, do you use silicone oil? I would say yes and no. It depends how severe the infection is. If you have determined retinal breaks, we can talk about that if you wish during the questions. Now, finally, I just want to tell you that we have conducted a study. I am, as was kindly said, the president of the European Vitreoretinal Society. We have conducted an audit of all the endophthalmitis cases which our members have had. This involved 253 patients, 64 doctors from 24 countries. I'm sorry to say there are only 2 from India, and I do hope that we have more of you coming to our meetings because you have a lot to give. Very, very high quality presentations, and I hope you do come. And the conclusions were more or less what I just told you. We would say that as opposed to the early vitrectomy study, which recommended not to perform vitrectomy, today I would say that the golden standard in endophthalmitis is early, complete vitrectomy. Thank you, and I would like to invite you all to our annual meeting in Lisbon, which will be in June from 27th to the 30th. We are still accepting abstracts if anybody wants to send them. Namaste.